evening. So tonight we're just going to talk a little bit about complications of inflammatory bowel disease. And for better or for worse, there are quite a few potential complications that can arise. Thankfully, most people don't experience any of these. But I think it's good to review what can happen and what sort of the management approaches might be for these specific things. So we're not going to cover everything comprehensively, but talk about a few issues which are often of concern to patients and their families. So I have to start by showing you pictures, and many of you in the room will have seen pictures like this before. There's images at colonoscopy of what things look like when you have active inflammatory bowel disease. And on the left is an example of someone who has ulcerative colitis. It doesn't show it very well with the lighting in the room. It might actually be better online. And on the right is an example of what the bowel can look like in someone with Crohn's disease. And in Crohn's disease, you can see these areas of deep ulcer. Those white lines are like little furrows. They're linear ulcers that can develop in the colon. And as you may know, if you get those linear ulcers that crisscross, it can look like cobblestones. And so you get that term cobblestoning as well. Well, we're going to focus a little bit more on Crohn's disease in this. And Crohn's disease is a condition where the lining of the bowel, in fact, the whole wall of the bowel can be inflamed. When something gets inflamed, it gets swollen and tender, as some of you will have experienced. And so that image in the top right is one of end of the small bowel joining the large bowel. So that little dangly thing is the appendix, and so that join between the small bowel and the large bowel is the most common area for Crohn's disease to occur. And this is an example of someone who has inflammation, so the lining of the wall of that small bowel is very thick and swollen, and you can see that that would be painful. It could lead to diarrhea. It could lead to bleeding as well. Well, that's sort of the if you want, the earlier stages of Crohn's disease. What we know can happen with Crohn's disease over time is you get this inflammation which comes on, that it might heal up, then it might get inflamed again. And just like any other part of the body where you keep damaging it, it heals, you can get a buildup of scar tissue. So some people with Crohn's disease develop what's in the top left corner here, which is a narrowing. That thick wall is all scar tissue, and so there's only a very small opening in the middle of the tube in the colon, and not surprisingly, that can lead to blockages. And so we call that a stricture. Stenosis is another word for narrowing, so that can be a consequence of Crohn's disease over time. Another thing that can happen with Crohn's disease that's not well treated or not treated adequately is that you can get these tunnels forming between different parts of the bowel, and these are called fistulas. And sometimes they can come together. If you get a narrowing here, the stuff has difficulty getting through, you get a bit of a buildup, and you get a little ulcer, and you kind of push into that ulcer, and we think those ulcers in the wall of the bowel can eventually eat away into whatever happens to be next door. And this is an example of someone who's developed a little tunnel between the end of the small bowel and another part of the large bowel. But fistulas can really occur in many places, as we'll see. So that'll give you a bit of history. Fistula is actually a Latin word for a pipe or a tube. And the famous lead pipes in the city of Rome, which had their own consequences, were actually called fistulas. And if you're interested, the Roman instrument, pan flute, was also called a fistula, but that's a happier version of the fistulas that affect people with Crohn's disease. So where can fistulas develop in Crohn's disease? Well, the most common place is around the backside. We call them perianal fistulas. These are tunnels that kind of appear in the surface of the skin around the anus and can lead to some other problems which we'll speak to. So over half of the fistulas that happen to people with Crohn's disease are down below around the anus, so we call them perianal fistulas. But they can affect other things as well. Very common challenge for women with Crohn's disease that affects the rectum right at the bottom is to actually get fistulas between the rectum and the vagina. We can also get fistulas from one part of the small bowel to another part, from one part of the small bowel to the large bowel, from the small bowel to the bladder. Really, any combination you can think of, unfortunately, can happen to people with Crohn's disease. And is it common? Well, these are some numbers from a long time ago, 16 years, but remember we were talking about what happened over 20 years, so these are people who probably got started on treatment with Crohn's disease in the 60s or 70s and were followed for 20 years. Well, back in those days, maybe 50% of patients over 20 years would develop some kind of fistula, and about a third of people with Crohn's disease would develop a perianal fistula over the course of their life with Crohn's disease. We think, and I believe it's true, that it's a lot less common now because we have better treatments for Crohn's disease. So the better we treat it, the better we control the inflammation, the less likely you are to develop these scar tissues, less likely to have these deep ulcers that lead to problems like fistulas. So I think, and we have some data recently to suggest that the likelihood of someone diagnosed with Crohn's disease in 2017 developing these fistulas is lower than the likelihood of someone who was diagnosed with Crohn's disease 30, 40, 50 years ago. Well, I've got to show you some anatomy, and sorry it's not the most pleasant thing. Some of you are enjoying some food in the room, and I apologize in advance. But this is a cutaway of a rectum, right? So this is the opening of the rectum at the bottom. This is the rectum above it. This is the skin of the buttocks across the bottom. And these sorts of stripy areas are the sphincter muscle that surrounds the anus. It's like a ring, but we're only seeing it cut in half. There's a, we call it internal one and an external one, but two sphincters. And a lot of fistulas that affect the backside around the anus begin at this line between kind of the outside skin and the lining of the bowel. We call it the dentate line. There are little glands there that can get infected and then lead to ulcers, and they can burrow away. And so often the fistulas begin around that area and track out to the skin. They can track out in different ways. And the problem is a lot of fistulas in Crohn's disease around the backside travel through the muscles, through the sphincter. So they can interfere with how the sphincter works, and that can lead to its own problems. But it also makes it very difficult to treat with surgery, because surgeons, if you have to cut open a tunnel that goes through the muscle, you end up damaging the muscle too, and that can affect things like continence. So we really try to avoid surgery for treating fistulas in people with Crohn's disease. But one problem that can happen are abscesses. This is another full color now picture of the backside, and the same things are seen here. And these are examples of abscesses. So if you get a tunnel that goes from the rectum, starts burrowing, it might go all the way to the skin, but it might come to a blind end. And if it goes to a blind end, fluid can accumulate in that tunnel, like a cave, but that fluid gets infected. When it gets infected, we call that an abscess. It can be extremely painful. If one of you have had this, people just can't sit down, and you can get a fever, and if it's not treated, you can get quite sick because of the infection, even spreading to the bloodstream. So we're very careful in people who have fistulas around the backside to make sure that they don't have an area of infection or an abscess. So we use different tools. We can use ultrasound, and it doesn't really show up very well, and ultrasounds are always hard to read unless you are an x-ray doctor or a radiologist. They tend to look like snowstorms, but I guess you'll have to trust me that there is an abscess here in this picture. But we also use a lot of MRI scanning now to try to take pictures of fistulas and to make sure that there's no fluid collection that would be an abscess. And again, this is an example of a picture of someone with Crohn's disease. This is like a cutaway cross-section across their pelvis. This is actually the rectum, the wall of the rectum, and you can see some little lines here. If you look, little dark lines that actually are pictures of a fistula around the anus. So this is probably our best X-ray technique for taking pictures of fistulas, figuring out where they start, where they end, and whether or not there's a collection of fluid called an abscess. Well, if you do have an abscess, it needs to be treated. And so that's when we often call on our surgical colleagues, not to get rid of the fistula entirely, but to deal with a problem like an abscess. When you have a collection of infected fluid anywhere in the body, you really have to drain it. You have to get that infected fluid out. So a surgeon will often cut a little hole over the surface of the abscess to allow it to drain. And sometimes put these little strings in called setons that are passed through the tunnel and tied on the outside, can dangle there, and that can be helpful in keeping both doors of the fistula open so that any infection can come out and it doesn't build up and cause an abscess. some of you probably listening online, or maybe even someone in the room has had to undergo a procedure where these setons are placed. A little bit of a nuisance having something dangling, but a lot better than having abscesses that come and go. We have medications as well. These are some pictures that were published in one of our big medical journals called New England Journal of Medicine 18 years ago now. It's a long time ago. These are some of the first experiences with using one of our biologic therapies, in this case infliximab, which was also called Remicade, for treatment of fistula around the backside. And we didn't used to have any medication that would actually close a fistula. So this was really quite impressive that you could give someone a treatment with the medication, and within 4 months these fistulas can close up. Not in everybody, but in a lot of people for whom we really had no other treatment options. So this really was a game changer 18 years ago. And it works not in everybody, it works in many people. These were some of the numbers from that big trial. So this is looking at how many people have got pretty good response, which means the number of open tunnels reduced by at least 50%. Of course, we want even better things. We want them to go away entirely. But this was quite good. But maybe about 2/3 of people on this dose of the drug did well, versus maybe only 1/4% of people who got a fake medication or placebo. So this is pretty good. It's a very useful therapy. Again, it doesn't help everybody, because there's still 1/3 of patients who don't respond. But for many people, this really changed things. And it can wear off over time. This is a trial following people who continued on treatment with that same medication for a year. And the people in yellow who kept getting the medication at fixed intervals did a lot better than people who got the placebo. But still a lot of people, the medication effects wore off over time. So we still need other options available to us. So are there surgical things? Well, people often say, well, if there's a tunnel, there's a hole, well, we can't just put a plug in it and be done with it. Well, it's kind of a logical idea, but unfortunately it doesn't really work very well in practice. There have been a number of devices created to do exactly that, to put a cork in the hole to stop the drainage, but it just really does not work. And there's been some very disappointing experience among surgeons trying to use plugs to block the hole. There are some surgical things you can do, and again, I won't go through the details of it, but in some people who have a very healthy lining, you can just core out that fistula and then pull a new surface over it, like a sheet, pulling up the bed sheets, and stitch that down to kind of cover it up. Again, it doesn't work in everybody. Unfortunately, these fistulas have a way of reforming, and so even this has had some disappointment. But it will show, and very unfortunately, some people have had to go to the extreme of getting a stoma just to bypass the whole area while it heals down below. We don't do this so much anymore, thankfully, because we've had better medications like the one I showed you. But I will show you some exciting information. So this is cutting edge, and it's not yet ready for prime time, but there's a lot of interest in using stem cell treatments for various aspects of Crohn's disease and ulcerative colitis. And this is a specific type of stem cell from the adipose tissue of a donor, get harvested, and they get processed and injected directly into the fistula tracts. So this is a very exciting new concept. Over the last few years, there have been some studies looking at whether these stem cells can close fistulas. And again, without going through the details, this was published last year in another big medical journal called The Lancet, but essentially showing that people who got this, just one injection of these stem cells, had a higher likelihood of closing completely the fistulas compared to people who got a fake injection of placebo. So again, not everybody responded, but some people responded to this who hadn't responded to other treatments. So this is another kind of therapy which is out there, and there are companies patenting these stem cells and looking to market them, and there'll be more trials coming, and who knows, it might be coming to a center in Canada in the near future. Right now it's not something you can access, but this was very exciting, completely kind of out of the box thinking on treatment to close fistulas. So some promise for the future. Well, to keep going, we're focusing on the colon here, but just to remind you that inflammatory bowel disease is kind of a disease of the whole animal. We kind of look at art a little bit. We can do colonoscopy and look at the bowel, but we have to remember that inflammatory bowel disease can affect really the whole body. And We often refer to these things called extra-intestinal manifestations of inflammatory bowel disease. So long words, but essentially meaning what it says, that things that can come along with inflammatory bowel disease that affect parts of the body outside the bowel itself. And there's a whole range of things that can affect people who have inflammatory bowel disease, Crohn's disease, or ulcerative colitis. And we won't go through all of these today. Lots of pretty pictures here, but I think that's not what you want to see. I think perhaps you want to know how common these things are. So these are the major categories of these extra-intestinal manifestations. We know that people who have Crohn's and colitis often have problems with joints. Not everybody, but these are various kinds of arthritis, things called ankylosing spondylitis and sacroiliitis that can affect the spine. And then peripheral arthritis, which can affect arms and legs and different joints. All of these can affect the patients with IBD, and maybe up to a quarter of patients will have some kind of arthritis associated with their disease. Skin things, or a couple of particular skin rashes, long Latin words again. We call these EN and PG for short. And they do affect people with Crohn's disease and ulcerative colitis as well. There are some eye changes that can happen, inflammation of the surface of the eye and of the pupil of the eye, called uveitis and episcleritis. And then there's some liver conditions as well. Again, PSC is something that can affect particularly people with ulcerative colitis. Thankfully, most people with Crohn's and colitis, if you look at these numbers, don't have any of these problems, but some can. And the other thing of interest is that some of these things kind of come and go depending on how active the Crohn's or colitis is. So when the Crohn's is in remission, these problems go away. When the Crohn's flare up, they can kind of tag along. So for example, arthritis in the knees and hips often comes and goes as the colitis comes and goes. So if your colon's all in good shape, you don't get the arthritis. If the colon starts to get inflamed, people say their knees start to ache. And that can happen to people. This other skin rash, erythema nodosum, you get these red lumps on the skin. Same thing. It can come and go with activity of the colitis. But there are other things here that can run their own course. They can happen before you develop Crohn's and colitis. They can happen after it and when it's in good control. Things like this other skin rash called, long word, pyoderma gangrenosum. Some of the inflammation of the spine joints and some of the eye problems as well. And this liver condition as well. So some of them kind of come and go with the IBD. Other things run their own course. So IBD is a condition of the whole body. I think that's an important thing. That's what we mean when we say this phrase, systemic comorbidity. So we've talked about these extra-intestinal things that can happen to patients with IBD. We know that people who are one autoimmune problem, such as Crohn's or colitis, can have other autoimmune problems as well. So you're just in that category that can predispose you to things like rheumatoid arthritis, thyroid problems, because these are all what we call autoimmune. You can have the consequences of having chronic inflammation, and some of what I showed you before, that scar tissue and even those tunnels can be in that category. And of course, over time, you can have problems with nutrition, which can have its own consequences if people with Crohn's or colitis aren't eating or aren't adequately nourished. Oops, wrong way here. So just in the last few minutes, thought we'd talk a little bit about osteoporosis. And then we'll talk a little bit about colon cancer, and I think this is a good news story with the latter. So this is an example of what osteoporosis does. It's a condition where the bones become brittle because the kind of the architecture of the bone gets broken down. So you can see there's a lot more space, far fewer girders on the right picture than there are on the left. So bones with bad osteoporosis are more prone to breaking. They're more fragile. And we know that people with Crohn's disease and ulcerative colitis have a higher risk of osteoporosis than people in the general population. So this is looking at Crohn's disease and ulcerative colitis. And with actual osteoporosis, which is this column here, depending on the study, anywhere from 1 in 14 to 1 in 3 patients with Crohn's disease might have osteoporosis. And it is a little higher than the background population. We have to remember that. Lots of things can cause osteoporosis, and I'm not an osteoporosis expert. We have bone specialists and endocrinologists who really treat this on our behalf. But we think that it develops for a number of reasons. One is that we use some medications that can affect the bones directly, and probably number one on the list is always steroids. It's one of the many reasons we try to use steroids repeatedly and for long periods of time, because we know steroids can have negative effects on the body, including contributing to osteoporosis. We also know that some people with Crohn's disease and colitis don't eat as well, so they may have a low intake of things like calcium and vitamin D. And all of us live in a northern climate, and we're prone to low vitamin D just because we don't get as much sunshine as people living in other parts of the world. So we're at risk, and that can contribute to osteoporosis. But a big thing is probably just having inflammation in the body. If there's some part of the body which is inflamed, you get these chemicals floating around the body driven by inflammation. And it turns out a lot of those chemicals that we call cytokines can affect the bone and slow down how the bone rebuilds itself. So the bone is always going on this reconstruction where it demolishes and rebuilds, demolishes and rebuilds. Well, what can happen in this situation is the demolition continues, but the rebuilding doesn't keep pace, and so you can develop more brittle bones as a result. This just shows you that steroids can increase the risk. This is a study from a long time ago showing that patients who get steroids are more likely to develop fractures in the vertebrae than people who don't get steroids. We'll tell you, these studies are a little messy because it's always hard to know whether it's the steroids themselves or the disease getting too active and needing steroids that was the cause of the fractures. But regardless, people who end up on steroids seem more likely to develop fractures and brittle bones. And in fact, this is from one of our guidelines from a group from the American College of Gastroenterology, reminding us that in patients with ulcerative colitis and Crohn's disease, we should consider screening for osteoporosis doing these tests we call bone mineral density tests around diagnosis and at some interval after diagnosis. We should keep an eye on that depending what the first result is. So certainly if people have required steroids for treating their Crohn's or colitis, you should be having your bone density assessed. And without getting into too much detail, you can think of yourself in three categories if you get a bone mineral density result. It could be normal, which is fantastic. In which case, you got to still work on prevention. And we'll talk about what some of those healthy preventive measures might be. At the other end, you could have true osteoporosis. You've already got it. In that case, we really should be seen by an osteoporosis specialist, and there are lots of different approaches to treatment which should be considered. Or you could be in the middle. We have this term for osteopenia, which means you're not quite normal, but you're not quite meeting the threshold for osteoporosis. And in that case, at minimum, we would repeat the bone density assessment in a couple of years to see if it's changing and keep a closer eye on you. And again, remind you of all the healthy things to do to prevent osteoporosis. So what are those preventive measures? Well, number one, as I already mentioned, is trying to avoid a lot of steroid exposure. Sometimes we have to use steroids, but we don't want to use it frequently or for long periods. Exercise, particularly weight-bearing exercise. All of you remember how astronauts often develop osteoporosis because they're not stressing their bones. So NASA has whole programs to make sure that astronauts exercise in space. Don't smoke and avoid excessive alcohol intake. Probably good advice for life in general. Calcium and vitamin D you should consume, and this, again, without going through this, this tells you how much calcium is recommended. So if we look at an average adult between 19 and 50, at least 1,000 and up to 2,500 milligrams of calcium a day is recommended in the diet. And for vitamin D, anywhere from 600 to 4,000 units of vitamin D a day. So if you drink milk, 3 glasses of milk would do this. But if you don't drink milk, you should look at other sources. And again, for vitamin D, sources include fatty fish, egg yolks, a lot of fortified substitutes for milk, cheese and yogurt, although they don't contain as much as milk. And for calcium, again, all the fortified milk and milk substitutes, but also things like dark green leafy vegetables. And if you like salmon and sardines and eat the bones, that's another good source of calcium as well. So very important to maintain intake of these things. Well, in the last few slides, I'll just mention another complication that people worry about in Crohn's and colitis, which is colon cancer. And we think that over time, if inflammation in the large bowel is not well controlled, keeps coming and going, that you build up over time a risk of colon cancer, because the bowel is always having to repair itself and fix itself. And the more times a tissue has to fix itself, eventually it can make a little mistake, and that can lead to cancer. And that's really why we think that Crohn's and colitis over time can increase your risk of colon cancer. Well, this is, again, old, 16 years ago, but things change quickly in our world. It's an old study which looked at trying to estimate what the likelihood of colon cancer is in someone with ulcerative colitis, in this case over 30 years of disease. And they estimate almost 20% of people would eventually develop colon cancer, which is a very high number. And it's certainly, I can tell you, not something we see in practice. And in fact, the good news is that if you look at more recent studies, the risk of colon cancer in people with Crohn's and colitis really seems to be going down quite quickly. And there's some lines here that show where one particular place in the world has looked twice in time, and almost always they see a dropping risk of colon cancer over time. And this blue line is at the risk of 1, which means that there's no increase over the background population, just like any other human being. And some of the studies, as you can see, when they look at their data, people with Crohn's and colitis are no more likely than people, just other human beings, developing colon cancer. That's a very good news story. And I can tell you, we think that this is both because we treat the disease better, so we control the disease, less likely to develop a complication, and also because we are a little more, I think, thorough and systematic about keeping an eye on things and talking to you about getting regular colonoscopies done so that we can find problems before they turn into cancer. So why do people with Crohn's and colitis develop cancer? Well, it can depend on how much of the bowel is affected. So the more of the bowel that's inflamed, the higher the risk, because you just got more surface area, more potential, more areas where the cancer can develop. If you've got more active disease, so how much of the bowel is affected, how active it is over time, and of course whether you already have a family history of colon cancer, that already puts up your risk. If you're diagnosed at a younger age, the risk becomes higher. And this is not common, but people who have this liver condition we mentioned before called PSC, they also have a higher risk of colon cancer. And I think the thing to remember with colon cancer and IBD, if it does develop, is it behaves a little differently from colon cancer in other people. You may hear people going for colonoscopy and having polyps removed to prevent cancer. Well, polyps, we know, are little growths in the bowel that are precancerous tissue, and if they're left there, they can turn into cancer. So many people, particularly those with a family history of colon cancer, have regular colonoscopies, and the goal is to look around, find polyps, and cut them out so they don't have a chance to grow up and become a cancer. Well, that's really what's seen at the top. You can see these little tufts of tissue, which are polyps, and we know that if we get them at the right stage, we can get rid of them completely. The problem with colon cancer in people with colitis is it doesn't usually go through that polyp phase where you can see it. You can get precancer changes that are really quite flat and hard to see. And so we have to pay extra attention. And so it's not just doing tests to see if they're polyps, it's actually looking directly at the bowel, examining the surface very carefully, and even if it looks normal, taking lots of little random biopsies to see if we can catch one of these precancerous changes in the act. Okay? And there's a medical word for that called dysplasia. So we're taking lots of biopsies to look for dysplasia because that's a precancer change. And if you develop dysplasia and you have a long history of colitis or Crohn's disease, then we have to talk to you about surgery as an option, because we get very worried that if you don't have cancer already, you might very soon. So this is what we do, and the lower right is what talked about with the general colon cancer screening. We look for polyps. We have these devices we can use to kind of nip them off, cauterize it, and remove the polyp. But really, in Crohn's disease and colitis, we're looking at the lining and taking samples from even healthy-looking tissue. And this can be hard to see. This is an example of someone with colitis. This picture in the middle all looks like just regular colitis, but if you do some special techniques and stain them, you can see that there's in fact a little kind of abnormal growth there, which is very hard to see. And even harder to see in this room with the overhead lights, but people online can see that a little better. And so you have to be very careful, look very carefully, and even take samples from healthy-looking tissue. So just the last couple of slides. How often do we do this? Well, it depends a little bit, and I won't go through all the detail. But depending on how your colonoscopy this year looks, and what we find, and what your background is, and whether you have a family history, and all that kind of thing, we might tell you to come back in 1 year, 3 years, or 5 years. So if everything looks great and there's really no inflammation, then we might stretch it out to 5 years because we know your risk is extremely low. So that's kind of a bit of a whirlwind tour of different complications that can happen in Crohn's and colitis. And we talked specifically about fistulas, extraintestinal manifestations, osteoporosis, and colon cancer. There's lots more we could talk about, but happy to address those in the questions. I know we have to get to our next speaker. Thanks. Good. Nice picture of Hamilton for you.
Thank you so much, Dr. Marshall.